And we'll introduce Dr. Ihab Saad. We'll introduce the next speaker.
I have the honor and pleasure to introduce Prof. Mohamed Gharieb, Professor of Intervention Radiology at Shams University. He will give a nice talk about actual effect of the IPS in Veno occlusive disease.
Bismillah ar-Rahman ar-Rahim. Thank you, Mr. Chairman. We'll talk about the effects of TIPS in Budd Chiari syndrome. Budd Chiari, it's a group of disorders characterized by hepatic outflow obstruction, starting from the level of the hepatic veins in the parenchyma up to the IVC in the whole course. They have two, it can be in the IVC, membranous web, complete or partial occlusion, or one or more of the hepatic veins. This is called Budd Chiari syndrome. Terminology, what is Veno occlusive disease? Because it's important to differentiate between both. Veno occlusive is a disease caused by a small hepatic injury to small venous sinusoids, usually due to exposure of toxins, now seen after bone marrow transplantation. So the term Veno occlusive disease is nearly obsolete and called now sinusoidal obstruction syndrome. This disease, we can see that in the CT, we have the picture of Budd Chiari. However, on Doppler examination, we can see patent hepatic veins. This is a medical condition treated medically and with even up to liver transplantation in liver cell failure. There is no role of TIPS in SOS or sinusoidal obstructive syndrome or Veno occlusive disease. This is a patient with Veno occlusive disease, a not-make appearance of Budd Chiari on CT. However, Doppler ultrasound revealed patent hepatic veins. This usually, as we see nowadays, after bone marrow transplantation or stem cell transplantation. Doppler ultrasound is the mainstay in the assessment of hepatic vasculature. If we find this triphasic waveform pattern, this is not a Budd Chiari. However, a monophasic flow may raise the suspicion and to be further investigated. It's postulated that a single well-drained hepatic vein, one of the three hepatic veins, if it's well-drained, this sufficiently decompresses the congested liver and is enough for the hepatic decompression in patients with Budd Chiari syndrome. So we start first with angioplasty and stenting in patients who have short segment stenosis not responding to medical treatment. If failed or not feasible, then we proceed for TIPS in patients with complete occlusion of hepatic veins, and even TIPS can be done in patients who are candidates for angioplasty, but the guidelines recommend we start first with angioplasty, then TIPS. Indeed, the experience of the operator and the center of expertise, all these are give the final decision in these patients. So patients with short segment stenosis, membranous web, healthy inflow veins, important, are the most suitable patients for angioplasty and stenting. Here you can see a right hepatic vein with a web at the junction between the right hepatic vein and the inferior vena cava. This is a very good candidate for hepatic venous stenting. However, in this case also can be candidate. However, in the last case, we can see that the inflow vein, although we can see there is a stenosis at the hepatic junction between the right hepatic and the IVC, however, the flow vein is unhealthy and thrombosed. So this patient is not candidate for hepatic vessel stenting. However, patients with extensive disease, absence of all the hepatic vein, long segment stenosis, not responding to angioplasty or stenting, these are the most suitable patients for TIPS. Also, the child classifications, the laboratory data, degree of hepatic fibrosis, Budd Chiari syndrome patients are managed using a multidisciplinary team, including interventional radiologists, hematologists, hepatologists, even vascular surgeons. Patient survival is significantly increased in patients with interventional therapy compared to medical therapy alone. This algorithm, we can see we do stenting in adults, in short segment stenosis disease, and if extensive disease, we have TIPS. This is an example of stenting. We can see here a short segment stenosis seen at the junction between the hepatic vein and IVC. And we can see here, this is the guide wire we passed. These are collaterals, and this is the hepatic stenosis, hepatic vein. This is a transhepatic approach, percutaneous. We can do a transjugular or transhepatic. Usually, we do in our institute transhepatic approach because we believe that negotiation with stenotic segments are easier through the transhepatic approach. And after we finish, we can coil embolize the tract to prevent bleeding. We can see collaterals, multiple collaterals seen. Then we put a stent first, and then we can see that slight disappearance of collateral. And finally, after balloon dilatation of the stent, we can see disappearance of collateral and cross of the pressure gradient across the stenosis. This is the before and after stenting. This is another case with IVC occlusion. We can see a short segment IVC occlusion. This is the femoral, in the femoral vein, the IVC. We can see a short segment stenosis of the IVC. Here we bypassed the stricture, and this is the artery from the catheter from the jugular vein. We can see the catheter from the femoral, and this is from the jugular. This is the stenotic segment. It was bypassed using a guide wire, and then finally we dilated the tract. The decision of stenting, we can see the collaterals. The decision of stenting in this patient is controversial. Indeed, in Egypt here, we don't have cadaveric transplantation. We only have living donor liver transplantation. So stenting in the IV of the IVC, this is the waist of the balloon at the junction. Yet it seems the stenosis in the first place seems longer, but however it's a web, and thrombosis is super added on it. Placing a stent in a patient which may later on need transplantation needs a good decision and consultation about these issues, because we putting a stent in a IVC near to the right atrium in a center or in a patient which may undergo living donor liver transplantation may be dangerous. What's TIPS? It's a percutaneous image-guided technique procedure. We create a channel between the IVC in cases of Budd Chiari syndrome and the portal vein. What are the indications of TIPS in general? Uncontrolled variceal hemorrhage, especially patients with recurrent variceal hemorrhage, refractory ascites, portal hypertensive gastropathy, hydrothorax, and Budd Chiari disease. There are no absolute contraindications for TIPS. TIPS may be life-saving procedure, but relative contraindications may be rated due to cardiac condition, unrelieved biliary obstruction, sepsis, thrombocytopenia, encephalopathy, and this is discussed case by case and patient by patient in each setting. Evidence of Budd Chiari syndrome, of TIPS in Budd Chiari syndrome, has a significant lower morbidity and mortality in patient than surgery, and is feasible in most patients Budd Chiari. This is a multi-center European study. They had 124 patients with Budd Chiari, underwent TIPS, show excellent 5-year transplant-free survival, reaching 88% and 78% respectively. Encephalopathy is extremely rare in patients with Budd Chiari. Maybe patients with refractory ascites or variceal bleeding may develop encephalopathy after TIPS. However, in Budd Chiari patients, it's extremely rare because these liver of these patients are congested, not cirrhotic, not fibrotic, no, more are congested. So when relieving the congestion, extremely rare to find varices. EASL guidelines, the European Association of Study of Liver Disease in vascular liver disorders, they say that the treatment of Budd Chiari must be a stepwise algorithm, medical treatment first and continues throughout the course of the disease, angioplasty, stenting, and thrombolysis in short segment stenosis, as we said, then TIPS, and then liver transplantation. And TIPS is a definitive treatment of patients with Budd Chiari. It's not asymptomatic. It's not only a salvage therapy or transient therapy. No, it can be a definite treatment of Budd Chiari disease. And we have patients from 2005 till now alive and well and doing good with excellent liver function and having TIPS patent along these years. Also, the American Association of Study of Liver Disease criteria in 2020, they say that TIPS or DIPS using the covered stents in the treatment of choice for Budd Chiari when medical therapy or angioplasty fail or not feasible, and surgical shunts could only be considered if interventional radiology procedures TIPS is not feasible or it fails. This study we published from our center, Dr. Shakir and us, on the Arab Journal of Interventional Radiology on 2021. We found these are single center experience. 118 patients underwent TIPS from the period from 2007 to 2014, and then we had a 5-year follow-up for these patients. And we found that the patency rates were 72 and 78% respectively. And the main problem with our study that we put what we call a bare metallic stent, not covered stents, due to economic factors in our country. However, we have a very good survival rate, although we have a higher re-intervention rate. But TIPS is an effective treatment modality for Budd Chiari syndrome with very long-term survival benefit and satisfactory shunt patency and patient survival. How to select a patient? As we said before, there are no absolute contraindication for TIPS. We select the patients according to the bilirubin, the albumin, the child score level, MELD score, procedure. Preparation, usually we do the renal profile, thrombocytopenia. In patients with Budd Chiari syndrome, we must search for the cause. As we say, we are in a multidisciplinary team. Hematologically factors, hereditary factors, antiphospholipid, protein C, protein S must be excluded and managed accordingly with the hematologist. Because if we put a stent and we do not treat the underlying condition, if it's treatable, the stent will occlude and the TIPS will be failed. So we use, first, it's important to have a good hepatologist and hematologist, rheumatologist in the management of these cases. Echocardiography is important because we shift the blood from the portal to the systemic circulation, so we must have a very good ejection fraction. And if a patient is ascitic, it's preferred that we do large volume paracentesis before the procedure to facilitate the procedure after on. This is what we call the classic TIPS technique. We do an ultrasound puncture of the right hepatic vein, and then we catheterize the hepatic vein with the catheter. This is a patient with not Budd Chiari, it's a variceal bleeding. We can see that the fundus of the stomach has the histoacryl particles. And then we puncture the liver through the hepatic vein to reach the portal vein, and we can guide using ultrasound, and then measure pressure gradient, put the stent, dilate the tract, and finally take the images needed. Modified TIPS, or what you call DIPS, we use ultrasound and fluoroscopic, usually because in the classic TIPS we showed before, they have a hepatic vein. These patients usually do not have a hepatic vein, and the caudate lobe is usually tough and enlarged. So puncturing the hepatic vein from the IVC, puncture the portal vein from the IVC may be difficult. Indeed, Dr. Mohamed has a very large experience in these cases, and he even punctures the portal vein from the end of the table, we know, without needles. But we see that combined fluoroscopic and ultrasonographic puncture of the portal and IVC may save time and save fluoroscopy and give us good results. We put a sheath in the jugular vein, And then we introduce the sheath down to the IVC and put a snare or a dormia or a guide wire and inside the IVC. And then we ultrasound, using ultrasound, this is the most important step of this technique. We puncture simultaneously the portal vein and the IVC. Here is our needle. We puncture first the portal vein and take portography using contrast and ensure, and then we direct our needle towards to the IVC. It's important to have these two structures in the same plane, and after which we can complete our procedure, snare the wire. This is the portography done to ensure our position, and then we continue through the liver parenchyma to reach the IVC. And then we pass a guide wire through this track, and then we complete our TIPS procedure as seen before. This is the wall of the IVC. We can feel the wall. And then we pass a guide wire. Snare the guide wire and go up to the, we balloon dilate the track with a balloon, 8mm balloon, and then dilate. This is the wall of the IVC. Pass a guide wire again beside this guide wire, and then we pass a caster, do a portography, dilate the tract, and put the stent and measure the pressure. Less than 12mm mercury pressure gradient is accepted and good in this patient. This is dilatation of the tract after. Then this is the bare metallic stent that usually we use. Covered stents now become expensive, and I don't think after our financial issues lately, how will it cost? ليه بقى 1000 جنيه 100000 جنيه بقى الانبوبه الدعامه ولا كام مش عارف تبقى بكام يا دكتور محمد تبقى بكام and then we take balloon dilate the track, and then to have the maximum length of diameter, as we see, we use usually a 10mm stent. As we see, encephalopathy is rarely seen in patients with Budd Chiari syndrome. Follow-up vital data is a risky procedure. The patient must be hospitalized. We do the hemoglobin at the end of the night, and if it's no drop, we must start anticoagulation immediately, because these patients are anticoagulated for life. As we say, there's medical management, including management of the cause, anticoagulation, and decompression therapy using TIPS. Follow up every 3 months by Doppler. We can do CT portography if in doubt. Complications are rare, usually bleeding, infection, thrombosis of the stent. Encephalopathy is rarely in Budd Chiari. How to avoid? Select the good patient. Use covered stents. It said it has less encephalopathy and smaller diameter in high-risk patients. TIPS is now has been widely used for more than 30 years to treat various conditions with patients with portal hypertension. It's not longer viewed as a salvage therapy or bridge to transplantation. No, indicated in several conditions, mainly Budd Chiari, to relieve the portal hypertension with positive effect on survival. Proper patient selection is the most important step in performing TIPS to ensure the best outcome with least complications. And thank you very much.
Thank you so much, Prof. Mohamed, for the nice, fruitful presentation. You did 118 cases of Budd Chiari in 3 years, 4 years?
What?
Single center.
No?
You did in a single center 118 cases of Budd Chiari syndrome.
Single center, yes. The more now, I think it's tripled now.
If you count that from 2013, it will be 1,000.
Yes, we did a lot of cases. I think it's tripled. We more than 500 cases in our institute, and maybe Dr. Mohamed have more than that, because Budd Chiari treatment is a misdiagnosed disease, and even the guidelines say that unexplained deterioration of liver function, you must search for Budd Chiari, and this is most our patients come to us like this. Patients with ascites, negative viral markers, examination by Doppler ultrasound, picks its Budd Chiari, and then it goes in his.
It's an outstanding number. Inshallah,
Yes, outstanding. We say that the center, the European center, multi-center study with 124 patients, and they made a dilemma for these. In our center, I think we have more than 500 cases of TIPS now, and Lincoln Dr. Mohamed have more than this. And we publish an international Egyptian registry of Budd Chiari. I think we will find a lot of cases more.
I believe we will have a lot of questions at the end of the session. Let's introduce our next speaker.
Okay, I don't